Good morning or good afternoon, depending on your location. Thank you for inviting me to be here today to speak with you. My name is Mike Dumont. I'm a Vice Admiral in the U.S. Navy, and I'm the Deputy Commander of U.S. Northern Command. We are based at Colorado Springs, Colorado. It's an honor to share some time with you today, and I appreciate the opportunity. In our brief conversation, I'll touch briefly on our military mission, our purpose, talk a little bit about the COVID environment and the assistance we've provided to state and local governments, and then mention about how partnerships with business have enabled our response and our posture throughout the pandemic. COVID-19 has created complex challenges, not only for the U.S. military, but for the entire nation, as you well know. And as we continue to perform our normal task of defending the nation and assisting the national response to the pandemic, it's also important for us to work to keep the U.S. military force healthy and able to remain postured so that it can handle national requirements and its deployment responsibilities. U.S. Northern Command has three primary missions. The first is to provide military assistance to civilian authorities. When a disaster strikes, for example, either man-made or natural, and the event outstrips the capacity of local, state, or federal agencies, then the Department of Defense is authorized to provide unique military capabilities in many of those circumstances. For example, during hurricane response efforts, we are routinely asked by the Federal Emergency Management Agency, or FEMA, to provide resources such as high water vehicles, search and rescue helicopters, and military manpower to assist. But because of the high cost to employ military assets, we strive to restrict our time in the affected areas to short duration. We also prepare for and remain postured to respond to other threats, a chemical, biological, or radiological or nuclear incident, a major earthquake, pandemic, or worse yet, a conflict with a near-peer competitor. We also provide additional security to major, widely attended events such as the Super Bowl, presidential inaugurations, national celebrations, and the State of the Union addresses. In short, we leverage military personnel and equipment to provide the necessary capabilities to help protect these events. We also have responsibility for homeland defense generally. This entails protecting the air, land, and maritime approaches to the United States. The depth and width of our homeland defense mission, as you can imagine, is enormous, but it's our number one priority. Unfortunately, we don't have enough time here to discuss that, all that it entails, but I will tell you it is significant, as you can imagine. Our third mission is our security cooperation or security assistance mission. That entails a cooperation with the other countries in our region, Mexico, the Bahamas, Canada, and they help us to better defend the homelands and to maintain military relationships between our countries. This is a cooperative approach to national security, and we maintain that approach through other nations in the region. Now, since the establishment of NORTHCOM after 9/11, we have nearly 20 years experience in responding to events that impact our national security. Through this, the most vital aspect is a strong relationship between the U.S. military and other federal agencies. Our ability to successfully address threats and other challenges is a result of lessons that we've learned over the years since 9/11. And the COVID-19 response capitalizes on our knowledge gained throughout those years of experience. We provide military assistance through DHS, the lead federal agency for the nation's pandemic response. And as we have seen, the problems we face with infection rates and the medical impact of the coronavirus are not only military problems and not only government problems. They impact every sector of our nation. In short, we need to come together to solve complex issues like this pandemic response. At the beginning of the pandemic back in January, as cruise ship passengers were returning to the United States, we worked closely with the Department of Health and Human Services and the Federal Emergency Management Agency, the states that were involved, and private sector partners to provide services such as temporary housing for these Americans. As the virus continued to spread throughout the country, state and local governments were challenged to respond and requested assistance from the federal government and from the military. And FEMA, as the lead federal agency, requested U.S. military assistance to help. Our original assignment in New York City was to provide non-COVID trauma and additional emergency care aboard one of our hospital ships and at alternate care facilities. However, given the rapidly changing environment and the spread of the pandemic, we had to quickly adjust to what I would call a three-pronged approach. First, our hospital ship handled trauma, emergency, and other urgent care cases, regardless of the patient's COVID-19 status. Second, a large alternate care facility became our primary medical treatment facility for COVID-19 patients. It's where we could provide ICU beds, oxygen generators, ventilators, and other medical capabilities that our military medical providers were able to provide. And third, we began to flow uniformed medical providers into local hospitals to augment their existing staffs in order to provide relief and increase the capacity of the local hospitals. As we expanded military support to a dozen states, we quickly implemented an adaptive approach to providing medical resources. Based on lessons learned from New York City, U.S. Northcom applied 3 conditions-based approaches. First, we placed military medical providers, doctors, nurses, respiratory therapists, corpsmen, and medics in local hospitals that had the greatest need. We also added modular capabilities to increase treatment capabilities in select civilian hospitals to essentially expand their physical space. And third, we operated from fully equipped alternate care facilities where available. Under this construct, we placed approximately 1,000 military medical providers in local hospitals in New York, New Jersey, Massachusetts, Pennsylvania, and Michigan. We also extended local hospital capacity in Connecticut and Louisiana, while providing fully equipped alternate care facilities in New York, Washington, and California. For the first time since Desert Storm in 1991, we conducted simultaneous deployment of 2 U.S. Navy hospital ships. And I'm sure many of you saw that on the news. Our National Guard and Reserve Forces provided doctors, nurses, medics, respiratory therapists, and placed them into hospitals where they could help. To date, we here at U.S. Northcom have overseen the delivery of $1.8 billion worth of military assistance. We've conducted 750,000 COVID-19 tests, and we've delivered 34,000 tons of bulk food and provided 44 million meals to people in need. Please know this level of support from your military is not possible without private and public partnerships and the help of the American people. As the need for help increased throughout the nation, we lacked a dynamic picture in real time of the demands on our military medical providers who were placed around the country. It was through our partnerships with various private entities such as Apple, Google, Esri, Palantir, Geospark, MIT Lincoln Labs, Verizon, T-Mobile, AT&T, and others that got us through this. We now have the ability to better track our forces and our military medical providers and enable real-time data to pass from those troops on the ground who are providing the care up to our headquarters and all the way in between. Industry partners have helped us by creating a series of applications for our mobile communications devices. We feel these types of innovations, as well as other digital initiatives, may well be the future of how we interface with our forces when they are providing disaster support across the nation. Partnerships matter, and the work done by industry partners and private business that have been supporting us have been particularly noteworthy. Industry has been on the forefront of our transformational efforts, and we continually benefit from your help and innovations to solve our homeland defense problem sets. My bottom line is this: the pandemic has been a wake-up call for all of us as a nation and as individuals, and it's been a true learning experience. This really should serve as a call to action, not only for your military, but also for businesses and the American people generally. We need to undertake more serious investment. We need to invest in preventive measures to make ourselves less of a target and less of a victim, whether from outside attack or cyber attacks or from a future pandemic. We really need to reinforce and harden things like our cybersecurity systems, our financial sector, our healthcare sector, our public utility sectors, our electrical grids, and many others. And while sad, this pandemic has provided us an opportunity, but only if we are visionary enough to see it and to act upon it and seize the opportunity. So with that, I would like to close just by saying thank you to the Chamber of Commerce for inviting me and for being a great supporter of U.S. Northern Command and the people of the United States military. I've appreciated this opportunity to speak with you, and I appreciate the opportunity to recognize our private and public partners and the American citizens, you all, for continuing to enable our success and providing solutions to the opportunities and the challenges we face as a military and as a nation. Thanks very much.
Thank you, Vice Admiral, for those remarks. That ties in perfectly with the theme for today, looking at collaborations and partnerships as we respond to COVID-19 and also look at future disasters, but also ties in very nicely to the theme of this keynote session, looking at how the future of disaster response is digital, and appreciated your remarks around innovation and partnership with some of those technology companies. So again, welcome back. Brooks Nelson here from the U.S. Chamber of Commerce Foundation. Excited to announce our next two speakers who are going to dive deeper on some of those innovations related to technology. So first up, we will hear from Lauren Gardner with Johns Hopkins University. I think many of us have been relying on their COVID-19 map, and she is here to share the origin of the map and the development of that. And then we will end today's session with Dr. Robin Murphy, who is an expert in disaster robotics from Texas A&M. And so we're excited to hear what she has to share. So with that, I would love to turn it over to Lauren.
Hi. Thanks, Brooks, and thanks very much for the invitation to be here. It's a real honor and exciting to get to talk to this audience. So I have some slides. There we go. And so my name is Lauren Gardner. I'm an associate professor in the Systems and Civil Department of Engineering at Johns Hopkins University. So one thing that is, I think, surprising for a lot of people is that I'm leading the efforts behind all of our tracking and mapping that's coming out of the university and my center at the school as well. And so it is interesting. This is actually all entirely hosted out of the engineering school at Hopkins, not the medicine and public health school, which is, I think, normally where this kind of work would be attributed to. And so there really is a lot of innovation going into these applications that are, I think, not normally associated with civil engineering that we do at Hopkins and at a lot of other universities. And so I've been leading this effort. We started in January, so almost 6 months now. And probably some of you have seen this map before. And so we've been tracking the epidemiology of COVID since it started, specifically focused for this purpose on collecting cases, deaths, and recoveries at a global scale. So next slide. And so the first thing I just wanted to recognize is that this is something that I could and would never do alone. It's a really collaborative effort that's based out of my center at the university and been supported primarily from the university from very early on, with a lot of support from the Johns Hopkins Applied Physics Lab, where we have a large team now of 15 to 20 different data scientists, researchers, software developers contributing towards these efforts, and also partner with Esri, who hosts the GIS technology and the platform that the map is sitting in. And then I just want to highlight Frank, my first-year PhD student, who has played a pivotal role in this whole effort and built the initial dashboard with kind of the idea of visualizing this data that we were collecting in the first place. So next slide. And also just to reference, so the dashboard is kind of two pieces. On one hand, it's the map, which is what everyone sees and what the public really interfaces with. But the thing about it that I guess that to me is, I think, the most valuable is the data that sits behind it. And that's what I'll talk to a bit more today. And the value of that data being publicly available in real time from the start. And that's really what the motivation was for creating this in the first place. And so we published a letter in Lancet back in mid-February, just providing a citable reference for anyone that wanted to use the data, and also documenting a bit about where that data sat, the protocol behind collecting it, and some of the evidence and validation of that data at the time. And so what is shown here, one is mainly the reference, but what we highlighted is that we consistently in the back end do comparisons of our data against other independent data sources. And so, for example, we compare data with WHO, for all countries in the world. And we similarly compare our data at this US state and county level against things like New York Times data and USA Facts data as well, to just continually validate and understand kind of some of these reporting trends and patterns and discrepancies if they exist. So next slide. And so just a quick overview of the map. Again, I think most people are familiar with this. It's a global map. We track all COVID cases reported anywhere in the world. And we provide that information at the country level for about 200 countries. For a number of those countries, we provide sub-regional data. And so that's what the Admin 1 tab is. And then for the US, we provide data at the county level. On the right side, there's a couple different lists. One of them is our global list of cases and deaths by country. The one on the far right is kind of the US-centric list, which tracks both US deaths and recoveries at the state level, and then also state level testing and hospitalization data, which we get from COVID Tracking Project. We have a time series that we present for all the countries and also all the US states on the bottom, and then multiple different map layers as well. So next slide. So we've added, or from the start, we've had a few, and then we have added a few as well, different map layers. So the first one is cumulative cases, which shows you the cumulative trend from the start of the number of total cases and death or cases around the world. But I think there's some other really important pieces to this. And so, for example, we have an active layer map, which shows the kind of real-time status of the outbreak. And so these represent the total confirmed cases minus deaths minus recoveries. So it's really showing where the outbreak is active at any point in time. We have a case instance rate map, which is the cases normalized, the confirmed cases normalized by population. We have a case fatality map, which is the number of deaths over number of reported cases. And then for the US, we also map out the hospitalization and testing rates that we collect. And so while this has been really adopted in the US, especially in the last few months, this map and the data, for me, the most interesting part of it and what really was kind of motivating it in the first place was understanding this more global perspective of what was happening with this, now a pandemic, and understanding these different variables and how they compare to each other and how they paint a different picture of the patterns and the trends and the true risk of COVID as it's moved around the world. And so I think looking at this as a global map is actually something that can tell us a lot about its behavior. So next slide, please. And so I have a couple slides here on the evolution of this dashboard. So we started this in January, and I just want to highlight, we started this at a time where there was not a single dedicated COVID web page reporting data anywhere. And so we had to start this collecting data in a very kind of unusual manner for public health reporting, where we were relying on things like Twitter and email correspondence telling us about new cases that we would then go and validate by digging up public health reports. And this was all manually collected and entered. And that was fine when there was a few hundred cases in China and one case in 3 other countries, but obviously not sustainable. Next slide. So what we have now is an architecture that has evolved over the last few months. It's still very much evolving. It's a very dynamic process to build this out and continually collect this data in real time, which again, we're doing for about 3,500 locations, multiple variables on an hourly basis, 24/7 all over the world. And so now we're collecting data directly from kind of what we call primary or authoritative sources that is getting up close to about 100 different sources at the moment that are different countries, counties in the US, states in the US, different sources that we pay a lot of attention to following and validating before we actually start automating data collection from them. And we pull all this data with some other aggregated websites as well, and collect it, clean it, curate it, process it, and then we send it through an anomaly detection system that we've also developed from scratch for this application that looks at every single number that comes in and essentially assesses it and compares it against the previous state's data to understand where there might be discrepancies that would be unusual, and it holds these numbers back and waits for us to manually validate and confirm them before it pushes them through to the dashboard. All this data goes through the GitHub where we share the data, and then is uploaded into the Esri dashboard. So it's mostly automated at this point with a manual error correction process in place. And again, the logic behind this anomaly detection system is continually evolving, as is the set of sources that we're collecting data from, and even the data that's reported in these sources. So next slide. And so some of the reasons that this is always evolving is because of some of these data collection challenges that we face. These are just a few I want to highlight, but there's many. Some of the challenges are in frequency and time of day reporting. We're dealing with a pandemic. It's around the world. So obviously we're getting data directly from these different countries that are reporting at different points in time. Some of them report daily, some hourly, some weekly. So we're having to deal with that. There's inconsistencies everywhere. There's inconsistencies in different how states report for a certain county in the US and how that county reports for itself. Similarly, between subnational regions and countries, there's inconsistencies in what's being reported. So some places have just confirmed cases, some combine confirmed with probable and distinguish those, some don't. Some report onset time, some report reported date. There's issues around testing and what are really counted as positives, what type of testing. So, and then a big issue for us that is something that needs to be addressed moving forward is the reporting medium. And so all sorts of different reporting mediums are used, some of which are really easy to get data from and some are not. Next slide. And just quickly, this data and this source has been obviously something that has quickly become the authoritative source, which grew out of this small academic team and really is leading and driving a lot of the decision-making around COVID all over the world. And so we quickly got up to about 1 billion requests a day after a month of having this data made publicly available. And then by around May, I think we were at 3 to 4.5 billion requests a day, which are just interactions on with the dashboard and people pulling the data from it. Next slide. And it's being used as well by, and the data itself was also one of the top trending accounts in GitHub, which we know also illustrates how the accessibility to it and the high volume of accessibility to it. And then in terms of who's using it, it's really everyone. And I think this it's everyone in the general public. It's, viral on all the social media platforms, everyone at all levels of government, both in the US and globally. Next slide. Also, it's been kind of the reliable source for most of the major news outlets as well. And so I just think this speaks to this huge gap that exist in terms of this type of data and this type of infrastructure being available, in real time at the very start of an event like this. And we filled this gap, and unfortunately, the gap existed. I think the good thing moving forward is that it will probably never exist again. There's just so much evidence that something like this has so much value, and there needs to really be this systematic, widespread infrastructure in place so that this kind of information can not only be collected and shared among government and public health authorities, but with the public, with the general public, and anyone that wants access to be able to use it. Next slide. And these are just a couple quick examples of its use. So it's being used in such a myriad of applications, but it really has been driving policy in the US. It's been adopted by all of the different forecasting groups that are doing modeling for informing most of the different public health planning teams. So the IHME model relies on this data, which was the White House task force was clearly relying on. And similarly, the CDC modeling efforts and the kind of ensemble model and forecast efforts that are done by that working group as well all use this data as a ground truth data and also to train their models. Next slide. And then just finally, it's also been kind of the starting point and the basis for the evolution of the Coronavirus Resource Center at JHU. And so this global effort that we were doing to just collect this case data has evolved considerably to all sorts of different, more longitudinal, deep analysis from global all the way down to community level of getting a better understanding of this COVID outbreak in real time. So we have our global map, we have this new US map that does a deep dive into each county with additional kind of county variables that you can look at around health infrastructure and socioeconomics, demographics. Next slide. And also looking at various critical trends and analysis using this data to illustrate patterns and gain a just general better understanding of the impacts of this, the fairness of it, the inequities of it, where it's being handled well and not, how policies change and are responding to it and impacting it. And so all of this stuff is available on the Coronavirus Resource Center, which has really been built around the data that we've been collecting and providing from day one. Next slide. I think that's it. And then again, in theme with this conference, this is a huge collaborative effort. So the work is being led out of our group at Hopkins and supported by Esri, but we have industry partners that have been providing resources from this for a while now. We heavily rely on Slack and GitHub and AWS for this. We have philanthropic funding to support the research team. And then in my research group, we have some government funding as well, supporting a lot of the research efforts that we're doing, building on this data that we've been collecting from NSF and NIH and NASA for various different research applications. So that's all I had to talk. I don't think I can take any questions here, but my email is available for anyone that does want to reach out with anything. Thanks.
Well, howdy, I'm Robin Murphy, and I'm going to be talking about disasters, how robots are being used to help with COVID. So it's a more physical aspect of how the digital age is impacting COVID. So let's go to the next slide. A little bit about me. I am a professor of computer science and engineering at Texas A&M, but I'm also an emergency responder. And I tell people I've been to 29 disasters, not of my own making. And that's starting with the World Trade Center, which was the first use of robots, all the way through things like Fukushima, Harvey, those types of disasters. Pandemics are one of those. And so we'll talk about that. Next slide. So, remember Ebola back in 2014, 2016, the big outbreak? Well, it was mostly in West Africa, but we got a little bit here in the United States, a couple of cases. And here in Texas, we had one Ebola patient, one person get it, $1 million in responding to it. I mean, between taking out that wing of the hospital, cleaning up the apartment, all of that, and 2 ambulances were taken out of service, right? So what city has enough money to have an 2 ambulances not be in service for a week while cleaning and decommissioning? So next slide. What have we done since then that's going to help address that? Because I was part of a team put together by the White House to look at these types of robots and see what we can do to do better on disinfecting, keeping, and protecting workers in society. Next slide. And so this is probably what you think we've been doing, right? Roboticists, we're coming up with some horrible, icky, auto-doc, scary thing, but you're going to be surprised. So what do you think is the #1 use of robots? And robots are being used quite a bit, and I'll show you some of the numbers. But what do you think the #1 use is? Next slide. Well, we'll tell you after we go through, just to give you a background on where it's coming from. We've put together 263 reports as of July 4th. My grad student Vignesh Ganduty's pulled them together from all over 32 countries, not 21, 32 countries as of July 4th. And here's what the #1 use is. Next slide. Public safety, not healthcare. Isn't that surprising? Public safety is where we're seeing the use of robots the most frequently reported in the press and social media. And we're seeing for a lot of reasons. One of them is for the quarantine enforcement, going over, looking, finding people using drones. Another surprise is taking these larger drones that you see down in the lower right, taking those agricultural drones, which do precision agriculture, precision spraying, and now adapting them to spray disinfectant in urban areas all over the world. Next slide. And now clinical care and healthcare, that's the number 2 use. And you're seeing hospitals, governments, insurers embrace the use of robots. Initially, most of the use was taking advantage of advances in commercial robots for using UVC to prevent hospital-acquired infections. So you're taking robots that already exist and starting to use them even more frequently, 24/7, to disinfect. But we're seeing a preponderance now of telesystems, of iPad on a stick, but telepresence to allow doctors, nurses, healthcare workers to help diagnose patients, interact with family, interact with patients without constantly having to put on and take off PPE, without being constantly exposed and interacting. So that's very cool. All right, what do you think the third one is? We've got public safety, we've got healthcare, or at least clinical hospital care. There we go. Third, continuity of work and education. Here's the big surprise to me, is seeing that now we're seeing individual companies, individual school districts, universities beginning to embrace robotics. So we already had robotics in warehousing, but now with the huge impact in industry and manufacturing and warehousing on increased demand with illnesses of workers, we're seeing an increase in that. And of course, schools, academia, workplaces need to be disinfected. Next slide. The fourth biggest use is just for us as individuals, things that we buy or purchase or consume. So, groceries are important. It's important to eat, but there's a whole nother aspect of socializing, of not just be able to see people on a laptop, but be able to get out into different locations. Like in this case, we saw in Japan, they graduated people through telepresence. At the same time, we've seen a person out in Cyprus walk his dog, have his UAV walk his dog since he couldn't go out. Next slide. The fifth biggest use is technically part of the healthcare, it's part of the medical industry. It's the laboratory and supply chain automation. So, the laboratories that do the testing for COVID are not necessarily next to the hospitals or the clinics that are doing the testing. And so you've got to get them there. And so in this case, you're leveraging those investments in delivery robots, like you see up in the top slide, to do that. Another thing that we're seeing quite a bit in the medical industry and supply chain is things like handling infectious materials, dragging. Why should you have a person risk their life by being infected with a needle with any of this type of infected waste? Next slide. And the next biggest case of that is non-hospital care. So it's not acute care, not in a hospital, but what if you've got those big quarantine camps where they've taken over hotels, and now you have to interact with all those people? What do you do about nursing homes where people are already ill or assisted living and they need some sort of life and getting to see their family? So here we're seeing the use of robots there, and you've seen both ground and aerial robots this. Next slide. So if you pull it together, you can see, look at the large number of robots that are being used for every possible category of application and every type of adopter, from government to hospitals to industry to us as individuals. Next slide. And what's fascinating to me is that even though many of those applications already existed, like the robots for the hospital acquired infections to prevent that, agricultural robots, look at these new markets or applications that we had never thought of before, like disinfecting, taking those agricultural drones and disinfecting public spaces, or using them to sanitize work in school instead of just hospitals. We've been looking at that interpersonal social distancing and how we can use robots to do things like see each other and propose marriage to each other and take care of that. Also, what's fascinating is construction robots coming in to assist and help for 24/7 construction of new hospitals. We've seen that in China, as well as taking over security. While all your staff is out, your facility is closed down, using robots to be the security guards with that. So we've really moved beyond telecommuting and delivery robots and drones. We're really going to new territories. And what we're very excited about is that we believe that this means that these markets are going to stick. They're going to be able to show that they're cost effective for regular use and that people now accept them. Look at the use in their everyday life, whereas something that was kind of over there for other people to use. Next slide. So when you think of robots, when you think of pandemics, don't think of scary, creepy robots like this. All right, next slide. Instead, I want you to think of robots as the ultimate in PPE for responders, protecting them, allowing them to work with patients or infected at a distance. I want you to think of robots as tools that can assist healthcare industry, everyone, with the surge in performing routine tasks, particularly in healthcare and laboratory testing and automation, and just keeping the hospital going. I want you to think of robots as support for keeping the economy going and growing despite worker illnesses. And ultimately, hopefully we'll see as well that it'll create new jobs and new opportunities at the end of it. Next slide. And if you want to learn more about the use of robots for pandemics, please check out Robotics for infectiousdiseases.org. That's a consortium that I'm one of the chairs for, where we try to keep post and keep up with what's going on in the world. And if you want to learn more about how robots are being used in everyday life and where the artificial intelligence comes in, please check out one of my 4 textbooks. Thank you.
Thank you, Dr. Murphy, for those remarks, and Lauren also walking us through the coronavirus dashboard. So we are now at time for this session. Some breakouts have already started, others will get started shortly. Do want to highlight that there's a demo by RMS at 2 p.m. that you can also join. And then we will be back here at 2:45 for our final general session, which will also include an Ask Me Anything with Deputy Administrator Carlos Castillo with FEMA. So have your questions ready. You can go ahead and put them in the chat box in that session, but he will be here to answer your questions. And though today is the last day of the conference, the fun will continue tomorrow. The Chamber is hosting a live conversation with Dr. Fauci, so encourage you to check that out as well. So enjoy the breakouts, and we will be back here at 2:45 p.m. Eastern. Thank you.